All the speakers since morning are talking about the surgical aspect of diabetic foot, and they have made my task a little bit easy. And I will be considering taking you through the how the perioperative management of diabetes is taken care during the surgical aspect of diabetic foot. So as we all know, diabetes mellitus is a common metabolic disorder affecting almost 9% of Indian population. Currently, 25.2 million adults are estimated to have IGT, which is expected to increase to 35.7 million by 2045. So patients with diabetes are at an increased risk of developing cardiovascular disease, peripheral artery disease, and neuropathy. These conditions, along with the microvascular consequences of prolonged hyperglycemia, often lead to higher number of surgical procedures compared to age and sex matched healthy adults. Preoperative evaluation, as we have already seen in earlier speakers' talk, what we have to look for. So diabetic patient require careful preoperative evaluation due to the complexity of glucose fluctuation, higher risk of silent coronary artery disease, which increases the likelihood of the post-operative infections and cardiovascular complication. So the now new concept is in the management or in the assessment of diabetes is variability in the glucose level. So you have seen now so many patients are wearing glucose sensors and all. So they are all to estimate the how blood sugar is jumping around or fluctuating. Surgery related tissue stress is always there. The interplay of nil per oral status preoperatively is always there. The duration of surgical procedure, the type of anesthesia, and factors such as altered meal schedules, nutritional intake, hyperalimentation, and emerging sepsis in patients with underlying soft tissue infections, otitis media, pneumonias, pyelonephritis, which are more prevalent in diabetics and can lead to significant variability in blood glucose levels, making them high-risk candidates. Factors like complexity of glucose excursion, high risk of silent coronary artery disease, and the potential for significantly variability in blood glucose levels due to surgery-related factors contribute to the increased risk of post-operative infections and cardiovascular complications in diabetic patients. So perioperative stress is generally contributed by general anesthesia and tissue stress associated with surgery set off a neuroendocrine stress response. This response leads to increased release of the counter-regulatory hormones such as epinephrine, glucagon, cortisol, and growth hormone. These hormones, along with inflammatory cytokines such as interleukin-6, TNF-alpha, results in increased insulin resistance and decreased peripheral glucose utilization. The result of these changes is hyperglycemia and ketosis in difficult cases. Preoperative stress has more to contribute during preoperative patient assessment, like in diabetics focuses on mitigating cardiopulmonary risk and maintaining strict glycemic control. CAD is more common in diabetics and is associated with increased risk of cardiovascular disease, cardiovascular autonomic neuropathy reflected by bradycardia, variability, tachycardia, orthostatic hypotension, and is common in diabetics and contributes to increased risk of coronary vascular disorder. Concomitant hypertension, obesity, cerebrovascular disease are further associated with poorer outcome in diabetic undergoing surgery. Adequate primary management of these conditions by intensive lifestyle modification and optimal pharmacotherapy is essential before elective surgical procedures. So types of diabetes that makes the difference is determine the patient's diabetes type, as type 1 diabetes are associated with high risk of diabetic ketoacidosis and require adequate basal insulin administration. So as we know, type 1 diabetics, they don't produce insulin in the body. So they are solely dependent on outside insulin supplementation. So that's why we have to be little careful about type 1 diabetes. Micro and macrovascular complication evaluate for underlying microvascular and macrovascular complication, including retinopathy. So every patient's fundus has to be examined. Neuropathy, nephropathy, and peripheral vascular disease assessment is required. Glycemic status, we have to check for HbA1c, EAG, and continuous glucose monitoring system. Evaluate for hypoglycemia, documenting important for frequency, timing, awareness, and severity. So with the help of CGM, we can find out if the patient is having cyclical hypoglycemia or hyperglycemia, then accordingly, the treatment or insulin doses can be changed accordingly. Medications review all ongoing medications, including insulin, oral diabetic agents, and other pharmacotherapies for underlying comorbidities. Then patient counseling is very important. The patient should be thoroughly informed about the details of surgery, including when to stop eating before the procedure, the type and duration of surgery, major or minor surgery, and whether continuous insulin infusion delivery devices like insulin pump, if used, can be safely continued intraoperatively. Then baseline workup should be done as per routine ECG, creatinine, HbA1c, fasting, and PP. Risk factors include like elevated HbA1c, abnormal Q waves, T wave inversion, STT changes suggestive of previous MI, and evidence of diabetic nephropathy associated with chronic kidney disease, and risk factors for major post-operative events. Further investigations are required. Then we go for the treadmill test or dovitamin stress echo, which may be considered on individual basis. Perioperative glycemic control goals are adequate fluid and electrolyte balance, avoid hypoglycemia and hyperglycemia, avoid fluctuation, prevent ketoacidosis, aim for the glucose range around 110 to 180. Individualization glycemic targets can be set if required, and monitor blood glucose levels regularly. So schedule surgery for early morning. This helps in minimizing blood sugar fluctuation while fasting, and stop SGLT2 inhibitors. Like most of the patients today are on newer drugs, and they are especially, most of them are SGLT2. So these medication increases the risk of urinary tract infection, dehydration, and acute kidney disease. Withhold oral hypoglycemic or non-insulin injectable drugs, especially if they are on glibenclamide or something, which is very long-acting drug, should be stopped few days before. This medication can also affect blood glucose control. Then there are specific considerations like oral antidiabetic. Metformin. Metformin is the most common drug used for diabetics, and it should be avoided. And actually, it is contraindicated in condition that increases the risk of renal hypoperfusion, lactate accumulation, and tissue hypoxia. Sulfonylurea, as I said, meglinotides, is a high risk for pre and perioperative hypoglycemia. It has very long half-life. Thiazolidines may worsen fluid retention and peripheral edema, should be avoided if there is a congestive cardiac failure. DPP-4 can also create a problem. So they alter gastrointestinal motility and worsen post-operative state. GLP-1 receptor agonist, this can also affect the gastrointestinal motility and worsen post-operative state, should be discontinued 24 hours prior to surgery due to their prolonged half-lives. Then comes the insulin. Insulin management is very important for all surgical patients, those who are going under surgery. Basal insulin accounts for approximately half of the individual's total daily insulin dose. Basal insulin should be continued even during periods of reduced caloric intake and perioperative stress to prevent ketoacidosis and limit protein loss. Reduce basal insulin doses by 10 to 25% the night prior to the surgery or morning of the surgery. Prandial insulin management. So these are the insulin which we use to control postprandial hyperglycemia. The optimal prandial insulins are like regular, Lispro, Aspart, Glulicin. For surgeons, insulin is the soluble insulin, which is the short-acting insulin. After fasting begins, we must stop this insulin, typically on the morning of surgery. For patients using fixed dose pre-mixed insulin, many of the patients are on fixed dose of the mixed insulin, and we have to reduce evening dose prior to surgery by approximately 20%, and at the day of the surgery should be reduced by 50%. And withhold the insulin if the blood sugar is less than 120 milligram. For patient using an insulin pump, continue with the usual basal insulin infusion rate. If the catheter and pump can remain safely in place, the patient will be awake and alert post-operatively. And if you think patient is not going to be alert, then we have to stop the insulin pump and shift them to multi-dose therapy. If the pump needs to be discontinued, administer basal insulin according to program insulin setting up to 2 or 3 hours before the surgery. Intraoperative monitoring. For long surgeries, over 2 hours, or surgeries with expected high blood glucose levels, coronary artery bypass, grafting, or like organ transplant, or use of the steroid during the surgery, perform intraoperative glucose testing every 1 to 2 hours. Use either laboratory or point of care testing, which is SMBG, and point of care testing may be less reliable in critically ill patients, those on vasopressor agents, or those who are hypertensive. In these cases, arterial blood gas or venous blood gas testing is useful. Administer supplemental short-acting or rapid-acting insulin doses as correction insulin. Typically, every 4 to 6 hours correction can be done. Continue correction insulin administration until the patient is eating or can resume oral agent, basal volume, bolus insulin regime. Delay metformin administration in patient with suspected renal hypoperfusion until normalization of estimated eGFR. Then comes the intravenous insulin infusion for long and complex procedure. So when the surgery is going to be for a longer period, then sometimes we have to give IV insulin also. So IV insulin infusion is often required for long and complex surgical procedures. Several IV insulin infusion algorithms exist in the literature. Insulin and glucose solution like GIK solution we have used all the time, and this is one of the standard practice to use it. IV infusion should be started early in the morning before surgery to achieve stable glycemic control. The short half-life of insulin, which is 5 to 10 minutes, allows for rapid adjustment. So there is a benefit. We can adjust the insulin drip rate every 5 to 10 minutes. In insulin, every half an hour more or so, and it can help us to control the glucose precisely. Then comes insulin regimens. To monitor glucose every 1 to 2 hours using laboratory or point of care testing, monitor potassium and bicarbonate levels, and GIK drip, single solution infusion containing 500 ml of the 10% dextrose with 10 millimole of the potassium chloride and 15 units of short-acting insulin is added. Initial infusion rate is 100 ml per hour. Adjust insulin doses by adding or subtracting 5 units based on the blood glucose levels. Monitor potassium level every 6 hours. So these are the standard ICU procedures which we all know that we are aware of, and we have to go as per the protocol. Then intraoperative monitoring, sulfonylurea, DPP4, GLP-1, SGLT2, and as we discussed, these are to be avoided. Then perioperative management. So glucocorticoids are mostly used in long surgeries, and this can worsen existing diabetes and causes steroid-induced hyperglycemia in patients without diabetes. So when blood glucose is 200 or above 200 or under the 200, any oral anti-diabetic medication can be used in patients with constant steroid dose with minimal glucose elevation. Insulin is necessary when glucose is above 200 and for patients started on high doses of steroid who have recent increase in steroid doses. NPH insulin is good option and it matches with the profile of the prednisolone, so it can be used. Morning prednisolone doses raises glucose levels by 6 to 10 hours, while longer acting steroids or twice daily dosing requires more prolonged insulin coverage. Patients on high dose steroid therapy often need 2 to 3-fold increase in their total daily insulin dose. So dose has to be increased whenever patient is on steroids. Then insulin dosing, special conditions like TPN and nasogastric enteral feeds that can increase blood glucose levels in diabetic patient. In diabetic patient receiving TPN, 80 to 100% of total insulin requirement can be added as a short-acting insulin dose to the TPN solution bag for administration over 24 hours. TPN order should be included in instructions to substitute dextrose infusion and recalibrate insulin dosing if the TPN is interrupted for more than an hour. Then there are some special requires like intravenous dextrose. This parallel line can be kept to prevent hypoglycemia, and changes of insulin regimes similar to TPN, continuous enteral feeding for more than an hour, recalibration of insulin dose is required. And there is requirement of effective communication between physician, surgeon, and dietitian, because they keep changing their diet pattern or calories. Then some emergency procedures require further attention, like monitoring blood glucose level every hour using finger stick or SMBG. And blood sugar should be kept at between 80 or 180, 80 or 100 or 150 according to the situation. So in conclusion, perioperative blood sugar control is a paramount importance as it dictates surgical outcome, hospitalization stay, post-operative complications, and financial burden on patient and their family. So this is, thank you very much.